Hello, everyone. Welcome to our lecture on peripheral vascular disease, which is part of our comfort concept. So under the umbrella of peripheral vascular disease, we're going to focus on two primary conditions, peripheral arterial disease and peripheral venous disorders. So these conditions affect blood flow, impacting our patients' comfort and their quality of life. So understanding these disorders is very important for providing effective nursing care. So we're going to go over the pathophysiology, clinical manifestations, and nursing interventions related to each of these conditions. So peripheral vascular disease refers to disorders that disrupt natural flow of blood through arteries and veins in peripheral circulation, resulting in decreased perfusion to the body tissues. So these disorders most commonly affect the legs rather than the arms. So peripheral vascular disease is a general term that encompasses two main categories: peripheral artery disease, or PAD, which involves the arteries that deliver oxygenated blood to the lower extremities, and peripheral venous disorders, which involve the veins that return deoxygenated blood to the heart. So while arterial diseases like PAD are more commonly associated with peripheral vascular disease, some patients may experience a combination of both arterial and venous conditions. So these conditions really can significantly impact a patient's mobility and their comfort. With an aging population and increasing rates of obesity in the United States, the prevalence and cost of managing peripheral vascular diseases are expected to rise. So in this lesson, we're going to look at some of the specific characteristics of both peripheral arterial disease and peripheral venous disorders. So we're going to start by talking about peripheral arterial disease, or PAD. And this is a chronic condition that results from systemic atherosclerosis. And atherosclerosis develops as the arterial walls thicken and plaques form, causing the vessel lumen to become narrower. So this narrowed lumen leads to decreased blood flow and oxygen supply to the affected extremities. PAD most commonly affects the lower extremities, and it's even sometimes referred to as lower extremity arterial disease, or LEAD. Obstructions in PAD can be classified as either inflow or outflow, depending on their location relative to the inguinal ligament. So inflow obstructions occur above the ligament and involve arteries such as the aorta and the iliac arteries, and outflow obstructions occur below the ligament, involving the femoral, popliteal, and tibial arteries. Gradual inflow obstructions might not cause significant tissue damage, but outflow obstructions often result in more serious complications, which we'll talk about later. So peripheral arterial disease poses very serious risks because it reduces perfusion to tissues, and it can lead to things like chronic angina, myocardial infarction or heart attack, or even a stroke. PAD is a marker for systemic atherosclerosis, meaning the affected individual is more likely to have similar diseases in other vascular beds, such as in the coronary or the carotid arteries. This condition affects approximately 8.5 million Americans over the age of 40, with African Americans disproportionately being impacted due to risk factors like diabetes and high blood pressure. So understanding peripheral arterial disease and its implications can help us recognize the importance of early detection and intervention. So the image here really gives a good detailed visual representation of how peripheral artery disease impacts blood flow. So on the left, you see a healthy arterial system with blood flowing freely to tissues. And then onto the right, the diagram illustrates the progression of peripheral artery disease. So as atherosclerotic plaques begin to develop along the arterial walls, you see the lumen narrows, which reduces blood flow. So in the center image here, you can see we have poor blood flow in that narrowed artery, where tissues downstream begin to experience oxygen deprivation. The far right image shows a blocked artery with complete occlusion caused by plaque buildup and a blood clot, which stops blood flow entirely. So this lack of oxygen and nutrients leads to tissue damage in areas below the blockage. So the consequences of PAD can range from intermittent claudication, which is pain during activity, to critical limb ischemia, where tissues are at risk of necrosis. So early identification and treatment are very important to prevent severe complications such as amputation of a limb. So keep this Picture in your mind as we discuss the different symptoms and the risk factors, as well as the nursing care that's associated with PAD. So looking at some of the major risk factors for PAD. So these include a combination of both modifiable and non-modifiable factors. So advancing age is one of the most significant non-modifiable risks, as the likelihood of developing atherosclerosis increases over time. Other non-modifiable factors include a family history of PAD and just the female sex. Modifiable risk factors are critical targets for prevention and for management. So high blood pressure, hyperlipidemia, and diabetes mellitus all contribute to the progression of arterial plaque and narrowing. Cigarette smoking is a leading preventable cause. It exacerbates vascular damage. Lifestyle factors like obesity, a sedentary lifestyle, and having an elevated CRP or C-reactive protein level all also can further increase the risk. Hyperhomocystinemia, which is a condition of having elevated homocysteine levels, is also linked to atherosclerosis and PAD. So patients who have these risk factors are not only at a higher risk for peripheral arterial disease, but also for systemic atherosclerotic diseases, which includes coronary artery disease and stroke. So by identifying and addressing the both modifiable and non-modifiable risk factors, we can really significantly help improve outcomes and enhance comfort for these patients. All right, moving into our nursing assessment for peripheral arterial disease. So this requires very careful attention to both the patient's reported symptoms and our physical exam findings. So let's start with pain. So the most common symptom that prompts patients to seek medical care is pain. And they often experience what's called intermittent claudication. So this refers to cramping, burning, or aching pain in the legs during a physical activity. This pain is typically reproducible, meaning that it occurs after a predictable amount of exertion and it subsides with rest. Over time, as the peripheral arterial disease progresses, then the distance that a patient can walk before pain occurs can decrease. And in more advanced stages, rest pain can develop. And this pain often feels like a burning or toothache-like sensation in the feet, toes, or the arches of the foot. And it may be severe enough to even disrupt sleep. So patients often report relief by placing their legs in a dependent position, such as dangling them over the edge of the bed to help improve blood flow. Rest pain is a sign of critical ischemia and it warrants immediate attention. So now let's focus on some of the other physical findings that we'll have during our assessment. So palpation of pulses is key. The most sensitive and specific indicator of arterial function is the quality of the posterior tibial pulse. As this is just because the pedal pulse sometimes is just naturally not palpable in some individuals. So that's why we go with the posterior tibial. So we want to carefully compare the strength of all pulses bilaterally so that we can detect any asymmetry or any absence. Capillary refill in the toes can also be delayed, which indicates compromised blood flow. On our inspection, we may see a loss of hair on the lower legs, along with dry, scaly, or even mottled skin. The affected extremity may even feel cool to the touch, and it can appear cyanotic or pale whenever it's elevated. Whenever it's lowered, the leg may have some dependent rubor, which is a reddish-purple discoloration, which is due to reactive hyperemia. Advanced peripheral arterial disease can also lead to muscle atrophy in the affected leg, and this is because prolonged ischemia reduces oxygen and nutrient supply to the muscles. We may see thickened toenails, and we may also see some ulcers on the feet, which are typically very painful, round, and they may be located on pressure points like on the toes. If they're left untreated, then these ulcers can progress to gangrene, which risk the limb viability. Listening for bruits over the femoral and iliac arteries can provide some additional evidence of a arterial narrowing or an obstruction, because these sounds indicate turbulent blood flow. So to diagnose peripheral arterial disease accurately, we have a variety of diagnostic tests that we can use. So we're going to go over some of the most commonly used methods. So an arteriography involves the injection of contrast into the arteries to visualize blood flow on an X-ray. So this is especially useful to identify any isolated areas of arterial occlusions, and it can also be used to help guide interventions like an angioplasty or a stent placement during the same procedure. Exercise tolerance testing. So this can be done with or without a treadmill. When it's done without a treadmill, usually it's chemically induced using certain medications. But so pulse volumes and blood pressures are measured before and after the onset of symptoms or after 5 minutes of exercise. So normally there is minimal change in ankle pressure during exercise, but in patients who have peripheral arterial disease, the ankle pressures may decrease by 40 to 60 millimeters of mercury. If the return to baseline pressures takes longer than 10 minutes, then this indicates that we have an abnormal arterial flow. Plethysmography is a test that evaluates variations in blood flow through the arteries using blood pressure cuffs that are attached to both the upper and the lower extremities. So a significant decrease in pulse pressure in the lower extremities suggests an arterial blockage. And also we get waveforms which are generated during the test. A flattened waveform indicates a more severe occlusion. We also have a magnetic resonance angiography, or MRA. And in this, we also use contrast to create a detailed image of blood flow through peripheral arteries. It's a very commonly used non-invasive tool to diagnose PAD. And then we also have an ankle brachial index, or ABI. So this is a very simple, inexpensive method to assess arterial function. So it's calculated by dividing the systolic blood pressure at the ankle by the systolic pressure at the brachial artery. A normal ankle brachial index value ranges between 0.9 and 1.3. An ABI of less than 0.9 is diagnostic for PAD. However, in patients who have diabetes, then the ankle brachial index value may be falsely elevated due to calcification of their arteries. So I want to talk just a little bit about whenever we're performing an assessment for PAD, it's very important to evaluate both the pulse amplitude and the neurovascular status of the affected extremity. So let's begin with pulse amplitude grading. So pulses are graded on a scale of 0 to +3. So a grade of 0 indicates an absent pulse, which means it can't be palpated. A grade of +1 reflects a diminished pulse that's weaker than expected. A grade of +2 represents a brisk, normal pulse, and a grade of +3 indicates a bounding pulse, which may represent an underlying condition such as fluid overload or a high cardiac output. So when we're assessing pulses in patients with PAD, again, we always want to compare bilaterally to detect any asymmetry. The posterior tibial pulse, again, is the most reliable indicator of arterial function in our lower extremities. Next, we're going to utilize the 5 Ps of the neurovascular assessment so that we can evaluate circulation, motor function, and sensory integrity. So our 5 Ps, we have pain, so we're going to assess for pain, especially at rest or with activity, which can indicate ischemia. We're going to assess the pulse. So again, palpate and grade pulses in the affected limb. Any weak or absent pulses may suggest a compromised arterial flow. Third, we're going to look at pallor. So with this, we're looking for any skin color changes. So a pale or a white appearance can indicate reduced blood flow, while dependent rubor suggests that there is a reactive hyperemia. Fourth, we're going to look for any paresthesia. So this is numbness or tingling sensations, which may indicate that there is some sort of nerve involvement due to the ischemia. And 5, we're looking at paralysis. We're checking the ability of the patient to move the affected limb because paralysis can indicate severe ischemia and or nerve damage. All right, so the graphic on this slide just really gives a good comprehensive overview of peripheral arterial disease, including its causes, risk factors, symptoms, and different assessment findings. So we're going to start with the definition of PAD. So peripheral arterial disease, again, occurs due to narrowing or blockage of vessels that carry blood away from the heart, most commonly caused by atherosclerosis. So PAD reduces blood flow to the extremities, and it can occur in any blood vessel, although it's going to be more prevalent in the legs than in the arms. So now let's talk about the risk factors. So smoking, high blood pressure, atherosclerosis, diabetes, high cholesterol, and an advanced age, especially over 60. Our symptoms of PAD typically involve pain. Again, that intermittent claudication, where the patient gets pain with exercise or movement, and then that pain goes away once they rest. However, up to 4 in 10 people may not have any sort of leg pain, but this is still a very critical assessment. And again, just kind of shows how any sort of physical assessment is very important for diagnosis. So continuing with physical assessment, there are some other key findings to look for. So again, any temperature differences between the legs, with the affected leg often feeling a lot cooler. Pale or bluish skin can indicate poor circulation. Smooth, shiny skin with hair loss may be due to chronic ischemia. A delayed capillary refill time in the toes may be seen. Swelling, although it's more common in venous disorders, may also be present. Sores or ulcers that don't heal, especially on the toes or on pressure points. You may see visual evidence of narrowed arteries, usually confirmed through diagnostic testing. Patient may have absent or weak pulses in the feet, which again is a hallmark of arterial insufficiency. And then lastly, they may also have cold or numb toes, which again suggests advanced ischemia or nerve involvement. All right, moving into our nursing interventions for peripheral arterial disease. So this requires a collaborative approach involving both non-surgical interventions and sometimes even surgery. So our goal is to improve arterial flow, reduce symptoms, and prevent complications. So some of our key interventions, so exercise. This is one of the most effective ways to improve arterial blood flow through the development of collateral circulation. So collateral circulation refers to smaller vessels that compensate for blocked arteries. So we want to instruct our patients to walk until they experience intermittent claudication pain, then stop to rest, and then walk a little bit further. So this gradual increase in walking distance helps to build tolerance and circulation. It's important to note here that patients with severe rest pain, venous ulcers, or gangrene really don't need to be participating in these exercise programs. Second, we have positioning. So positioning recommendations aim to promote circulation without compromising arterial perfusion. So we want to teach patients to avoid crossing their legs or wearing constrictive clothing that might impede blood flow. We want to avoid elevating the legs above the level of the heart because extreme elevation can slow arterial blood flow to the feet. However, if a patient has some swelling, then sometimes moderate elevation might be helpful. But typically we want to teach these patients to keep their legs dangling down. So third, we need to promote vasodilation. So vasodilation can be encouraged by providing warmth to the affected extremity while avoiding any prolonged exposure to cold. So we want to recommend that patients maintain a warm home environment and wear insulated socks or shoes to help keep their feet warm. However, they need to avoid applying any direct heat, such as like a heating pad or a hot water bottle, because they have reduced sensitivity in their affected limb, and this can increase the risk of burns. Cold temperatures and stress, as well as substances like caffeine and nicotine, cause vasoconstriction. So we really want to stress to patients the importance of avoiding smoking and chewing tobacco, as the vasoconstrictive effects of each cigarette can last up to even an hour. Fourth, we have drug therapy. So our antiplatelet agents like aspirin, clopidogrel, and pentoxifene are very key in managing peripheral arterial disease. So these medications can reduce blood viscosity, they can improve blood flow, and prevent clot formation. So pentoxifene works by increasing the flexibility of red blood cells and reducing fibrinogen levels, which enhances blood flow to the extremities. While there is some there's limited evidence of how effective the pentoxifene is, some patients still find that it improves their ability to perform basic activities like walking to the mailbox or even to the dining room. Clopidogrel is another very important drug, but patients need to be sure to avoid grapefruit and grapefruit juice while they take it, because it can lead to very severe complications like kidney failure, GI bleeding, or even heart failure. Statin medications like simvastatin or atorvastatin can help lower lipid levels, which reduces the cardiovascular risk. It also kind of helps with that atherosclerosis. Silostazol, which is a phosphodiesterase inhibitor, can be prescribed to improve walking distance and increase HDL cholesterol levels. However, we need to be sure to let our patients know that it can have side effects like headaches, flatulence, and diarrhea. And fifth, we need to worry about controlling hypertension. So managing blood pressure is very important for improving tissue perfusion while avoiding any excessive constriction of vessels. So we want to teach patients how hypertension affects circulation and stress the importance of adhering to treatment plans. Patients who are on beta blockers need to be monitored very closely because these medications can sometimes worsen claudication or other symptoms. So as you can see, it's very crucial here that we individualize our interventions based on each patient's condition and their needs. So by combining exercise, proper positioning, vasodilation techniques, drug therapy, and blood pressure management, we can significantly enhance a patient's comfort, their functionality, and their overall quality of life. So whenever our non-invasive measures are insufficient to improve arterial flow in patients with PAD, invasive non-surgical procedures can be effective alternatives. So we're going to go over some of the primary procedures and the associated nursing care. So first we have a percutaneous transluminal angioplasty or PTA, and we can also have a laser-assisted angioplasty. So a PTA is an invasive intra-arterial procedure performed under local anesthesia where a balloon catheter is advanced through a cannula into or above an occluded or stenosed artery. The balloon is then inflated, which dilates the artery, and it opens the vessel and improves arterial blood flow. In a lot of cases, they may place a stent, which is like a wire mesh device, into the vessel during the procedure to maintain the vessel patency and to prevent any reocclusions. So stents are really effective for treating stenosis in the common or in the external iliac arteries. So while a percutaneous transluminal angioplasty can be highly effective, reocclusion can also occur and some patients need repeat procedures. So outcomes really vary with this procedure. Some patients remain occlusion-free for 3 to 5 years, while some may have a reocclusion within a year. And with a laser-assisted angioplasty, so this just involves advancing a laser probe through a cannula to the site of arterial stenosis, and then the laser vaporizes the atherosclerotic plaque, which creates an open lumen and helps improve blood flow. Another procedure that we can do is a mechanical rotational abrasive atherectomy. So this technique uses a rotational device, also often called a rotablator, which scrapes away plaque from inside the artery. It minimizes damage to the arterial wall, and it's especially useful for treating lesions in smaller arteries like the popliteal or any artery below that. So our nursing actions following these procedures, we want to carefully monitor for bleeding at the arterial puncture site. We're going to assess vital signs, peripheral pulses, and capillary refill regularly so that we can ensure adequate circulation. We need our patients to remain on bed rest with the effective limb kept straight for 2 to 6 hours post-procedure, and this is just to reduce the risk of bleeding or hematoma formation at the site. We're going to administer anticoagulants or antiplatelet therapies as prescribed. These are medications like heparin during the procedure, and we may administer clopidogrel or aspirin post-procedure. Antiplatelet therapy is typically going to be continued for about 1 to 3 months after the intervention to prevent any sort of arterial clot formation. So all of these procedures are often performed in a same-day surgery or ambulatory care center, which makes them very convenient, and they're less invasive options for improving blood flow. So when PAD disease progresses to severe claudication, breast pain, or a risk of losing a limb, then surgical intervention may be necessary. So the most common surgical procedure for PAD is arterial revascularization therapy, which aims to restore blood flow to the affected limb. So we're going to break this down a little bit further. So The procedure is performed for patients who are experiencing, again, that severe claudication that impacts their ability to function, if they have rest pain at night, or if they have an imminent threat of limb loss. So during revascularization, bypass grafts are used to reroute blood flow around arterial occlusions. So grafts may be autogenous, meaning that they use the patient's own veins, such as the saphenous vein, which is preferred for outflow procedures. Or grafts may be made by synthetic materials, which are used when autogenous veins are not available. So preoperative care. So preoperative preparation includes assessing and documenting vital signs and peripheral pulses to be able to establish a baseline. So patients may require antibiotics before surgery to prevent any post-op infections as well. Post-op nursing care. So this is very important to be able to ensure the success of the procedure and to prevent any complications. So nursing actions are going to be to monitor circulation. So we're going to regularly assess the location of pedal or dorsalis pedis pulses. We're going to mark these locations and compare pulsatile strength with the contralateral leg using a Doppler. We're also going to evaluate the color, temperature, sensation, and capillary refill of the affected limb. Changes can indicate compromised circulation or complications. So speaking of complications, we're going to be assessing for these. So again, we're looking for signs of warmth, redness, and edema, which are often expected due to increased arterial perfusion. So that we want to see these. But we are also going to monitor for signs of infection at the incision site. So this would be like excessive redness, drainage, or swelling. Pain management. So as we know, post-op pain is very common. It should be managed effectively so that we can encourage mobility and recovery. Blood pressure monitoring is also important. It's also carefully regulated. So hypotension can increase the risk of graft collapse or clotting, whereas hypertension can increase the risk of bleeding or graft rupture. And then some additional patient education. So we're going to teach patients to avoid smoking, limit their dietary fat intake, and to increase their protein intake to be able to promote healing. We also want to encourage hydration to prevent dehydration, which could exacerbate vascular complications. And we'll ensure patients with chronic PAD that ongoing monitoring and interventions can help prevent further progression and help improve their quality of life. So that wraps up our peripheral arterial disease, and now we're going to start looking at peripheral venous disorders, which occur when problems with the veins begin to interfere with the adequate return of blood from the extremities to the heart. So this results in things like blood stasis or pooling, which can lead to a range of complications. So the veins in the lower extremities are divided into deep and superficial veins, both of which are equipped with valves. So valves prevent backflow of blood as it travels upward toward the heart. And it's the action of the skeletal muscles, such as during walking, that plays a crucial role in promoting venous return by compressing the veins and pushing that blood upward. So when veins aren't working properly, they can become distended, and patients may present with various signs and symptoms. And there are three primary conditions that can alter blood flow in the veins. We have venous thromboembolism, or VTE, venous insufficiency, and varicose veins. So a venous thromboembolism, so this term encompasses, again, deep vein thrombosis. It also, kind of a play off of this, is a pulmonary embolism, or PE. So a DVT involves the formation of a clot deep within a vein, usually in the lower leg or the thigh. And if the clot dislodges, then it can travel to the lungs, which causes a PE, which is a potentially life-threatening condition. Venous insufficiency occurs whenever defective valves fail to maintain proper venous return, which leads to chronic pooling of blood. So symptoms may include edema, skin discoloration, and the development of venous stasis ulcers, which are very challenging to heal. And third are varicose veins. So these are dilated, tortuous veins that are caused by valve insufficiency. While they're not life-threatening, they can cause a lot of discomfort, swelling, and some cosmetic concerns for patients. So it's also important to note here that skeletal muscle inactivity can impair venous return. So for example, when patients are immobile or they have reduced muscle tone, the lack of muscle contractions hinders the blood flow in the veins, which exacerbates this venous stasis. So our goal of nursing care for peripheral venous disorders is to promote venous return, prevent complications, and provide education to patients on lifestyle modifications such as physical activity and proper positioning. All right, so again, peripheral venous disorders arise from problems with the veins that interfere with adequate blood return to the heart. So these issues result in blood stasis, which leads to a lot of different complications. The deep and the superficial veins in the lower extremities play a big role in preventing backflow of blood through their valves, which is, as we know, aided by the action of the skeletal muscles during things like walking. However, when these veins or the valves don't function properly, they become distended, which leads to symptoms like swelling, discolorization, and again, those ulcers that I talked about. So again, on this page, we're just kind of going over, again, those three main categories of disorders affecting venous blood flow. So we're just going to get a little more in depth than I did on the last slide. So with a venous thromboembolism, or VTE, this is a formation of a blood clot in a vein. So this causes it's the result of venous stasis, meaning that the blood has pooled there. And what does blood do when it sits still? It clots. It can also be due to an endothelial injury or just hypercoagulability disorders. All of this, we will learn about more about VTEs in the clotting concept. So VTEs, this includes a deep vein thrombosis, or DVT, and a pulmonary embolism, which we talked about previously on the last slide. But also to note here, thrombophlebitis, which is an inflammation of the vein with a thrombus, is another manifestation of this. So chronic insufficiency and chronic venous disorder, this is kind of where a lot of our focus is for peripheral venous disorders. So venous insufficiency occurs due to incompetent valves in the deep veins, which prevents efficient blood return to the heart. So we see pooling of blood, increased venous pressure, and dilation of veins. Chronic venous insufficiency results from persistent venous high blood pressure, and it's characterized by swelling, skin discoloration, venous stasis ulcers, and even sometimes cellulitis. So our varicose veins, so these are, again, enlarged, twisted veins that are caused by weakened or damaged vein walls and valves. They're usually found in the lower extremities. They're often cosmetic, but they can contribute to a lot of venous insufficiency over time. So they're the result of increased venous pressure and a loss of elastin, with abnormal collagen patterns weakening the vein walls. So as far as our clinical application here, some key points. So proper functioning of veins depend on open or patent valves, or competent valves, and the assistance of skeletal muscles. Those damaged or obstructed veins are what lead to progressive venous disorders like chronic venous insufficiency. And again, patients may report different symptoms, and we're going to talk about these a little more in depth in a few more slides, but leg heaviness, cramping, and visible vein changes. And then we also need to be sure we give education on lifestyle changes, such as regular leg movement and avoiding prolonged standing, because these can help manage symptoms and it can actually prevent progression. All right, so let's get into our risk factors. For a venous thromboembolism, our risk factors align with what's called Virchow's triad. And again, I'm not too worried about VTEs for this concept, but for your clotting concept, we will focus a lot heavier on DVTs and VTEs. So Virchow's triad is hypercoagulability. So this occurs in conditions like pregnancy, cancer, or in the use of oral contraceptives and certain genetic disorders. The second part of Virchow's triad is impaired blood flow. So this results from immobility or a sedentary lifestyle. And the third piece of the triad is vessel wall damage, which is caused by trauma, surgery, or inflammation. So our risk factors for venous insufficiency and chronic venous disorder. So having prolonged venous hypertension is the primary cause. Our common contributors are things like sitting or standing in the same position for extended periods, usually due to like jobs or occupational demands. Obesity increases pressure in the venous system. Pregnancy adds additional strain on the venous return. And things like thrombophlebitis, inflammation of veins with clots, which is what thrombophlebitis is, also exacerbates venous dysfunction. There are risk factors for varicose veins. So there are some predisposing factors. So female sex, and this is just due to hormonal influences and structural differences in our valves or in the veins. Occupational risks, such as, again, prolonged standing like teaching or in healthcare roles, us as nurses really need to be aware of this. Obesity and pregnancy place extra pressure on the venous walls and then on the valves. Systemic diseases like heart disease or conditions that affect circulation are also a risk factor. And lastly, family history of varicose veins indicates some sort of genetic predisposition. All right, so moving into our nursing assessment. So peripheral venous disorders usually present with characteristic signs and symptoms that help us recognize underlying venous insufficiency or varicose veins. Again, like I said, we're focusing on venous insufficiency and varicose veins, not DVTs for this lecture. So starting with limb pain. So patients usually describe an aching sensation or a feeling of fullness or a heaviness in their legs that happens after standing for a prolonged period of time. So for venous insufficiency, upon our physical assessment, we may see what's called stasis dermatitis, which is kind of a reddish brown discoloration along the ankles that can extend to the calf. A lot of you guys have probably seen this on some of the patients you took care of in the nursing home in your level 1 clinical. Edema is another key finding, particularly in both legs. So over time, stasis ulcers can also develop, which usually appear over the medial malleolus or on the inner ankle. And these ulcers typically have irregular borders, they're very difficult to heal, and in severe cases they can lead to amputation or even sometimes can ultimately lead to death. When it comes to varicose veins, you'll see distended superficial veins that are just beneath the skin that are really tortuous in nature. Patients sometimes report muscle cramping, aching pain after prolonged sitting, and sometimes they can even have pruritus, which is itching in the affected areas as well. So finally, it's really important to remember that chronic venous insufficiency and related conditions can significantly impact patients' quality of life. So for example, an untreated stasis ulcer, these are a major concern, and recurrence is very common, and it can lead to very serious complications if they're not properly managed. All right, so let's get into some of our nursing interventions for managing chronic venous insufficiency, focusing on both symptom relief and ulcer management. So first, we address pain and edema while promoting venous return. So using graduated compression stockings are a cornerstone of treatment. So these stockings need to be worn during the day and during the evening. We want to educate patients on proper sizing and how to use them. This is essential. We need to emphasize not rolling those stockings down and ensuring that they're not too tight. This is because rolling them down can essentially cause like a tourniquet effect. So we really don't want that to happen because that's going to impede blood flow even more. Leg elevation is another critical intervention, ideally for at least 20 minutes, 4 to 5 times a day, and whenever the patient's in bed. The legs need to be elevated above the level of the heart. So you see this is a difference between PVD and PAD. So remember, in peripheral arterial disease, we want the legs to be down, but in PVD, especially chronic venous insufficiency, we want those legs to be elevated up above the level of the heart. Some additional measures, especially like in the hospital, we can utilize intermittent sequential pneumatic compression devices or SCDs. And we can also teach patients about exercise and weight reduction strategies. For patients who have a venous stasis ulcer, promoting healing involves some advanced therapies like a hyperbaric oxygen treatment or a wound vac system. So pain management is important to our care of these venous stasis ulcers. And the choice of dressing really depends on the type of ulcer. So an oxygen permeable polyethylene film works really well for superficial ulcers, while an occlusive hydrocolloid dressing like a Duoderm is very effective for deeper ulcers, and they need to remain in place for about 3 to 5 days. Artificial skin products, although they can be very expensive, can also be used to help difficult to heal ulcers. If the patient is ambulatory, then an Unaboot can be utilized. So this is a gauze dressing that's moistened with zinc oxide, and it forms a rigid cast-like structure whenever it's applied, from the toes to the knee. So this UNABOOT promotes venous return and it protects the wound. Patients should be advised to report any increased pain because that might indicate that the boot is too tight. Lastly, dietary recommendations play a big role in wound healing. So we want to encourage patients to include zinc, protein, iron, and vitamins A and C into their diet so that we can support recovery. So as you can see, after going through all of this, education is a big piece of venous insufficiency management. Patients really need to understand the importance of consistent treatment, strategies to manage their condition, and ways to prevent recurrence or complications. All right, so now we're going to focus on interventions for managing varicose veins. So the main goal here is to improve and maintain optimal venous return to the heart while preventing disease progression. So the recommended first line of treatment includes the 3 E's, so elastic compression hose, exercise, and elevation. Compression stockings apply external pressure to enhance venous return, and they come in various strengths, usually ranging from like 8 to 10 millimeters of mercury. These are the same stockings we talked about on the last slide. So exercise, that second E, is essential to be able to promote circulation, but it's important to avoid high impact activities like horseback riding or running. Instead, we want to encourage daily walking and ankle flexion exercises while sitting. Elevating the legs as much as possible is also very beneficial as gravity helps to prevent that venous reflux. So for patients who have persistent symptoms or cosmetic concerns, surgical options are available. So these include vein stripping and sclerotherapy, where a irritating chemical is injected into the vein to cause a localized inflammation and collapse. Larger veins may require incision and drainage of trapped blood for a few weeks after the injection, with pressure dressings being applied post-procedure. A less invasive modern alternative is an endovenous ablation, which uses ultrasound guidance to occlude a varicose vein. So with this, we insert a catheter into the vein and inject that anesthetic agent before it's ablated, which is like lasered off. Post-procedure care includes wearing compression stockings for 24 hours daily, except during showers for at least a week. And then follow-up ultrasound ensures that the vein is closed, and we need to monitor this patient usually up to about 8 weeks to help track healing and address any potential complications like a DVT or any nerve irritations. So remember, all these treatments usually require long-term use of compression therapy and regular monitoring to achieve the sustained benefits. All right, so for this slide, we're just going to talk about the key differences between peripheral arterial disease and peripheral venous disease, or PVD. So these conditions both affect the circulation in the extremities, but they do so in very different ways. So peripheral arterial disease occurs due to narrowing or blocking or a blockage in the arteries, which reduces oxygen-rich blood flow to the distal extremities, such as the hands and the feet, with the legs and the feet being predominantly more so affected, which leads to ischemia and oxygen deprivation of the tissues. On the other hand, peripheral venous disorders are caused by issues in the veins that interfere with the return of blood to the heart. So we start to see things like pooling or stasis of blood in the distal extremities, especially the legs. So let's look at the symptoms. So starting with PAD. So again, PAD patients often experience sharp pain, particularly that intermittent claudication, which is cramping or pain during activity that's due to reduced blood flow. They can also have cool skin, absent or weak pulses, a pale or bluish appearance in the extremities, and hair loss on the affected limb. Ulcers that are caused by peripheral arterial disease are typically have like a punched out appearance with very defined and round edges and occur most often on pressure points like on the toes or on the heels, and gangrene is a very possible complication. For PVD, these patients report symptoms such as a dull aching pain or a heavy sensation in the legs, which is often worse after prolonged standing or sitting. Signs of venous insufficiency include things like warm skin, that brown and brownish discoloration, which is known as stasis dermatitis around the ankles, and edema. And the ulcers that are seen in PVD tend to have irregular edges and drainage, often appearing around the ankles or on the lower legs. And again, these wounds are very difficult to heal and can persist for years if they're left untreated. As far as temperature and edema goes, so a simple way to differentiate between these conditions is temperature. So peripheral arterial disease leads to cold extremities because they have reduced blood flow, whereas PVD, peripheral venous disorders, have warm extremities because they have pooling of blood. Also, edema is common in PVD. It may be seen in peripheral arterial disease, but it's definitely not as common as what's seen in peripheral venous disorders. For treatment and management, so for peripheral arterial disease, the goal is to improve arterial blood flow. So our treatment strategies are things like antiplatelets, like aspirin. We also can use clopidogrel. Statin medications are used, like atorvastatin or simvastatin, and they're used to manage cholesterol levels. Lifestyle changes like smoking cessation and a low-fat diet and regular exercise are used. And again, we're going to teach our patients with PAD to dangle their legs to promote blood flow. So for PVD, or peripheral venous disorders, the focus for treatment is on improving venous return. So compression therapy like elastic stockings is going to be key to reduce swelling. Also, again, we want to elevate the legs and also implement regular exercise. Anticoagulants may be prescribed to prevent any clot formation from happening. So a little tip to remember here, you can kind of see there on the slide, if you make your fingers, your index finger and your middle finger, if you point them down like an A, then your legs dangle. That's how you know PAD, the legs need to dangle. Or if you kind of do like almost like the peace sign, that's your fingers make a V, and that's elevate. So for PVD, we want to elevate the legs. So kind of like think of your index finger and your middle finger being your two legs. So PAD, they're dangling down. PVD, they're making a V and they're up above the level of the heart. So that's all I have for this lecture. See you guys in class.